There are 5 surgeries that doctors perform every single day on people just like you that I would never ever allow for someone I love. I've spent over 12 years working with patients over 60. I've sat in hospital rooms. I've read the charts, and I've seen what nobody warns you about before you sign the consent form. The surgery goes perfectly, the doctors are pleased, and then everything falls apart. Today I'm telling you exactly which 5 procedures scare me most and what you can do instead. This could be the most important thing you watch this year. My name is Dr. Eleanor Mercer. I specialize in health and wellness for adults over 60. For more than 12 years, I've focused on one question: what actually helps older bodies and what hurts them even when it works? What I'm about to share isn't what most surgeons will tell you in a 15-minute appointment. It's what we talk about among ourselves. It's what I would tell my own mother. By the end of this video, you'll know which 5 surgeries carry the highest hidden risks after 60, why the hospital environment itself can be dangerous for older adults, and the exact questions to ask before you ever agree to go under the knife. Everything in this video is for educational purposes only. It is not medical advice, and it does not replace a conversation with your own doctor. Every person is different. Please always talk to a qualified healthcare provider before making any medical decisions. Now, let's get into it. 1. Hip replacement after 75, the surgery that worked but destroyed a life. Let me tell you about a woman named Gloria. She was 73 years old, sharp, funny, loved her flower garden. She fell on her porch steps one afternoon and fractured her hip. She went to the hospital. The surgeon was excellent. The procedure was technically perfect. Gloria woke up in recovery and smiled at her son. 3 days later, she didn't know where she was. By day 5, she didn't recognize her son. Within 2 weeks, she had pneumonia. Then she lost so much weight she couldn't stand up for physical therapy. What was supposed to be a 5-day hospital stay turned into 6 weeks. Gloria never went home. She went to a nursing facility instead. The hip healed perfectly, but Gloria, the real Gloria, never came back. This is called postoperative delirium, and it is far more common than anyone tells you. A major study of over 15,000 patients above age 70 found that nearly 40% experienced measurable cognitive decline after surgery. Not temporary confusion, actual lasting decline, still present 6 months later. Here's why. Anesthesia drugs build up differently in older brains. They interact with medications you're already taking. They disrupt systems that are already delicate. Every hour under general anesthesia after 70 increases the risk. And hip replacement is one of the most common surgeries performed on people in their 70s and 80s. Am I saying never do it? No, I'm saying the calculation changes dramatically after 75. A 2024 British Medical Journal study followed 8,000 hip surgery patients over 75. 1 year later, 28% had not returned to their previous level of function. 15% were living in nursing homes. The surgery had a 95% technical success rate, but the real-life success rate, much lower. What to ask instead. Before agreeing to hip surgery, ask your doctor about intensive physical therapy, targeted pain management, home modifications, and mobility aids. Ask, what happens if we try conservative management for 3 months first? You might be surprised by the answer. Stay with me, because the next one is even more important, especially in emergency situations. 2. Emergency colon surgery. When there's no other option is not true. When doctors say the words emergency colon surgery, most people freeze. They agree immediately. It sounds urgent. It sounds like there's no time to think. I want you to stop, take a breath, and ask questions. Here's the reality. The mortality rate for emergency colon surgery in patients over 70 is between 15 and 25%, depending on the study. That means up to 1 in 4 people over 70 who have this surgery don't survive it. And for those who do, many face colostomy bags, months of recovery, digestive problems that never fully resolve, and a level of fatigue that changes everyday life permanently. I had a patient, I'll call her Sandra. She was 74. She had diverticulitis, inflammation in part of her colon. It flared up badly one night, and the ER team recommended emergency surgery. Her family was terrified. They were ready to sign the forms. But Sandra's daughter asked one question: is there any other option? That question saved Sandra's life, or at least saved the life she wanted to keep living. A geriatric gastroenterologist was called in. He recommended aggressive antibiotics, complete bowel rest, and careful monitoring. Sandra stayed in the hospital for 8 days without surgery. She went home. She recovered fully. Many situations that feel like emergencies can actually be managed medically if you have the right specialist in the room. What to ask? Before any emergency colon surgery, ask for a geriatric gastroenterologist to be consulted. Ask, can we try antibiotics and bowel rest first? What are the exact risks of waiting 24 hours to evaluate all options? You're not being difficult, you're being smart. 3. Perforated ulcer surgery in older, frailer patients, when the cure is worse than the disease. I need to tell you about someone who meant a great deal to me. During my training, there was a retired physician. I'll call him Dr. Harold. He was 77, brilliant man, still reading medical journals at his kitchen table every morning. He called me from the emergency room one evening. He had a perforated ulcer, serious, potentially life-threatening. The surgical team said he needed emergency repair. We talked for a long time that night. Harold knew the statistics. He'd seen what recovery looked like for men his age. He looked at me and said, Eleanor, I've seen this surgery save people's lives. I've also seen it take everything that made their life worth living. I want to know the real odds. The real odds for perforated ulcer surgery in patients over 75 are sobering. Mortality rates in most studies sit between 30 and 50%. And for those who survive, many spend weeks in intensive care. Many never regain the level of function they had before. Harold chose surgery. He wasn't ready to give up, and I respected that completely. He survived. But he told me months later that if he had fully understood what the recovery would take from him, the piano playing he lost, the energy to read that never came back, he might have chosen differently. The surgery saved his life, but it took the life he wanted. Now, I'm not telling you to refuse surgery in a true emergency. Perforated ulcers can be fatal without treatment, but there are specialized centers now exploring conservative management in carefully selected patients, aggressive antibiotics, drainage procedures, intensive monitoring. It doesn't work for everyone, but it exists and it's worth asking about. What to ask? What is my specific mortality risk for this surgery given my age and health? Are there any centers or specialists with experience in non-surgical management of this condition? If your surgeon gets frustrated by that question, ask for a second opinion. You have that right. Always. Coming up, the 5th surgery might surprise you because it's one most people think is totally routine. 4. Bowel obstruction surgery, enterectomy, the hidden domino effect, nobody explains. Here's something I want you to picture. Think of your body as a line of dominoes. When you're 45, those dominoes are spread far apart. One falls, you have time to stop the rest. When you're 75, those dominoes are standing much closer together. One falls, and the whole line goes. This is what doctors call the cascade effect. And nowhere is it more dangerous than in bowel obstruction surgery, the removal of part of the small intestine. One complication triggers the next. The surgery causes inflammation. The inflammation causes the bowel to stop moving. The bowel stopping causes nausea and malnutrition. The malnutrition slows healing. The slow healing causes infection. The infection requires more antibiotics. The antibiotics cause more digestive problems, and on and on. I've watched patients come in for what seemed like a straightforward procedure and leave 3 months later having survived sepsis, pressure sores, hospital-acquired infections, and severe muscle loss. None of which were complications of the original surgery, but all of which were triggered by it. I had a patient, Dorothy, 82 years old. She had a bowel obstruction. She survived the surgery. She's alive at 85 today, but she told her daughter something that stayed with me. They saved my life, but they didn't save my living. Chronic pain, permanent dietary restrictions, fatigue that never lifted, loss of independence. She said if she had known, she would have asked about palliative care instead. Here's what many people don't know. A significant number of bowel obstructions can be managed without surgery. Bowel rest, a tube to decompress the stomach, careful monitoring, close observation. Many resolve on their own. The key phrase to know is there evidence of dead bowel? If there is, surgery may truly be unavoidable. If there isn't, push hard for a trial of conservative management before consenting to the operating room. What to ask? Before we go to surgery, can we confirm whether there is actually dead bowel tissue? If not, what are the risks and benefits of trying non-surgical management for 24 to 48 hours? 5. Appendectomy after 80, the simple surgery that isn't simple anymore. Everyone thinks appendectomy is easy, in and out in an hour, back home in a couple of days. And for a 50-year-old, that's often true. For an 80-year-old, the picture is completely different. In patients under 60, the mortality rate for appendectomy is less than 1%. After age 80, it jumps to 5 to 8%. That's 5 to 8 people out of every 100 who do not survive what everyone called a simple surgery. Why? Because older patients often wait longer before coming to the hospital. The appendix has already ruptured. Sepsis sets in fast, and the older body doesn't have the reserve to fight back the way a younger one does. Here's what changes everything. In some cases, antibiotics alone can work. A 2023 Scandinavian study showed that in elderly patients with uncomplicated appendicitis, no rupture, no abscess, approximately 70% resolved successfully with antibiotics alone. No surgery, no anesthesia, no recovery. This is still considered controversial in many hospitals. It won't work for everyone, but the option exists and you have every right to ask about it. What to ask? Has imaging confirmed whether my appendix has ruptured? If not, am I a candidate for antibiotic-only treatment? What are the risks of that approach versus surgery? A doctor who respects you will answer those questions honestly. I know what you're thinking. Dr. Mercer, what if it truly is an emergency? Fair question, and my honest answer is, true surgical emergencies absolutely exist. Uncontrolled internal bleeding, clearly dead tissue, active, fast-spreading sepsis. But here's what 12 years of experience has taught me. What gets called an emergency and what is actually an emergency are sometimes two different things. Unless you are actively bleeding or have confirmed dead tissue that will cause sepsis within hours, you likely have time to ask a question, time to request a second opinion, time to understand your options. A 24-hour delay for proper evaluation in many cases does not change outcomes. It can change the quality of the decision you make, and that changes everything. Before any major surgery, do these 5 things. Step 1. Ask for your frailty index score. This is a validated 5-minute tool that predicts surgical risk in older adults. If your surgeon doesn't know what it is, that is a red flag. Step 2. Request cognitive baseline testing. Simple memory and attention tests done before surgery. Repeat them 6 weeks and 3 months after. If decline happens, it's documented, and it may change your decision entirely. Step 3. Ask directly, what are the non-surgical alternatives, and why are we ruling them out? If the surgeon says there are none, get a second opinion from a geriatrician, not another surgeon. Step 4. Ask about the PUSM score. This is a surgical risk calculator specifically for older patients. It gives you a real percentage chance of complications and mortality based on your specific situation. If your surgeon hasn't mentioned it, ask why. Step 5. Update your advance directive with specific language about quality of life. Write things like, if surgery would likely result in nursing home placement, I choose palliative care instead. Or, I prioritize my cognitive function and independence over extended life at any cost. Make your values crystal clear so your family knows what to fight for when you cannot speak for yourself. Let me give you the fast version of what we covered today. Hip replacement after 75. High technical success rate, low real-life success rate. Ask about physical therapy and pain management first. Emergency colon surgery. Mortality up to 25% after 70. Push for specialist consultation before consenting. Perforated ulcer repair in frail patients. 30 to 50% mortality in some studies. Ask about conservative options. Bowel obstruction surgery. The cascade effect is real and devastating. Confirm dead bowel before agreeing to the OR. Appendectomy after 80, no longer a simple surgery. Antibiotics alone work in many uncomplicated cases, and the 5 steps: frailty index, cognitive baseline, ask about alternatives, POSM score, update your advance directive. That's everything for today. If this gave you something useful, something you'll bring to your next doctor's appointment or share with someone you care about, then subscribe. I post new videos every week on exactly these kinds of conversations, the ones that don't always happen in the exam room, but absolutely should. Take care of yourself, and take care of each other.